So blood gas interpretation, I know this is something that has not in the past been routinely taught in paramedic school. I think it should be. It's actually questions can on the National Registry can have blood gas analysis on the questions. If you're doing transport and you're taking respiratory patients, they're probably going to have blood gases for you to review. So having an idea, and again, if we take it to the next level where you can actually perform them, and you can see, because things can change very quickly. So what we're looking at is we're measuring pH, oxygen percentage, carbon dioxide, and sodium bicarb. That's the four big things that I want to know about. The bicarb probably be the least of the four, unless certain conditions show up on the other three. If you look at that little chart there, it gives you the normal values. And the pH 735, 745, if you think normal value of end-tidal CO2, which is 35 to 45, you're kind of in the same ballpark. Is the first thing to look at is the pH. If the pH is normal, they're compensating in some way. Maybe it's been a chronic problem. The body has produced more bicarb over time and they're balancing out. So if the pH is normal, generally you can consider that either there's nothing wrong with them breathing wise or handling it fine, or the body has compensated in some way. So that's the first thing you want to look at. Then I would suggest looking at the CO2. If the CO2 is between the norms, the 35 to 45, and the pH is normal, that means their ventilation is okay because they're managing it. Now, if that CO2 is high and the pH is normal, something has had to intervene to keep that pH there, and that's a slower process where you're going to have an increase in production of bicarb to balance that higher CO2. Probably something that you don't see as much pre-hospital, or you might see it in critical care transport because it takes a little bit longer to get there. So you might see the bicarb or the HCO3 to be higher to balance that higher CO2. Typically what you're going to see in respiratory failure, remember they're running out of gas, the pH is going down, the CO2 is going up. The bicarb is too slow of a process to balance that. And that's one of the key things that we're looking for is that respiratory failure side of it. Then if the patient's pH is normal, CO2 is normal, you could have a bicarb issue, but it's probably going to be normal. But if the pH is high and the CO2 is normal, it's a metabolic problem. So you're looking for, is this a respiratory issue or is this a metabolic issue where they're not producing enough bicarb, that type of thing like that. That's more of the acute things. But the pH is your key piece of information in their stability and their compensation and their managing of what's going on. Then you look at the CO2, then you look at the bicarb. O2 is really not part of the acid-base balance, but it is giving you an accurate number as compared to your pulse ox of where their oxygen levels are. So those are the four things I'm looking at, is, again, pH being number one. Okay, now we'll talk a little bit about mechanical ventilation. Now, of course, this can be a whole, semester program on mechanical ventilation. So this refers to using a device to provide ventilatory support. Now, it could be just in the CPAP mode, could be just in a BiPAP mode. It could be in a total control mode where it's doing everything. So there's a lot of options that you can have. So they range from some things that are very complex to some that are less complex to do that. But now you're starting to see even the transport vents, the smaller ones, are coming with a significant amount of capabilities. It used to be an ICU vent was more complicated than a transport vent. What I'm seeing now, they're getting pretty close to the same. In fact, there's a new mode out there. I don't know if people have seen it much. Is a CPR mode. I was taught early on, if somebody was on a ventilator and they went into cardiac arrest, you take them off the ventilator and you manually ventilate them, because the machine, it didn't work well by doing that. You'd have a conflict between the machine trying to give a breath and somebody trying to compress the chest, and things didn't work well. But now you have a CPR mode, and where the technology is, you can leave them on the vent, put it in a CPR mode, and the computer, basically probably using AI, to be able to coordinate the ventilations with the compressions. So you might have ventilations that might be as high as 100 to match the compressions, but they've determined that this is an effective way of doing it. So it's this, taking them off the vent is not the standard anymore if you have a machine that has that capability. Classifying has become more challenging due to biotechnological advantages. The first ventilator that I used to change the volume, it was a hand crank. You had to hand crank a bellows to change the volume. Now it's all, and the ventilators were huge. Not quite as big as the one in the picture there. Now they're much smaller tabletop devices. So a lot of changes in technology. The vent is your lifeline in transport, and we have to master some of this, of what you're looking at, and maybe taking a whole course just on mechanical ventilation and using the device. Obviously, whatever device that you may have on your transport unit would be the one you really want to be proficient at, because things can change rapidly, and it's not time to be looking it up on your phone or something. So indications for mechanical ventilation: acute hypoxic respiratory failure. The patient's gone into failure, they can't control their CO2, it's rising rapidly. Hypercapnic respiratory failure is the CO2 going up. So we got the first one being your oxygen down, second one being your CO2 going up. Airway protection. A person is not able to protect their airway. They're going to need to be put on a ventilator. Some of these patients, if they're on vents long enough, they'll have trach tubes and go from there. A lot of times they want to get the tubes out of the patient's mouths because of oral hygiene, comfort, and those type of things. So you're going to do some transport. You may see patients that are trached. Increased work of breathing is another reason they're running out of gas. They can't do this work any longer. Somebody's got to step up, and the machine's going to take it over. Respiratory muscle fatigue. You got somebody with neuromuscular disease where they're not strong enough to be able to do the work anymore. Or they might not be able to do it at night. So they sleep at night, they're on a ventilator in the daytimes that they're not. Post-operative ventilation. Patients coming out of anesthesia, and they might be on a ventilator. There's a lot of places that every patient that has anesthesia, they get about 30 minutes of BiPAP afterwards. They actually recover faster. Some people say that's a standard, especially a patient who has a history of obstructive sleep apnea probably needs to be on BiPAP after surgery. So if you've got a patient that has gone through some sedation, maybe that's something to look at for non-invasive ventilation, especially with your larger patients. So clinical stuff, respiratory rate greater than 30. How long can they continue to do that? And is it keeping that pH in that normal range? If their oxygen level and their blood gas is below 60, they're not oxygenating very well. Maybe have to be put on a ventilator to do that. CO2 above 50, they're becoming acidotic. Now remember, if this is a blood gas where the patient, it's been in a chronic problem, that 50 may not be dropping the pH at all because the body is compensation metabolically and being able to manage it. So that might not be a clear indication without looking at the complete picture. SpO2, again, you're looking at your sats less than 90 and they're on oxygen therapy. It's something that clinically could indicate a need to be on a ventilator. I would like to hope that people would try maybe non-invasive ventilation before going on a vent. Negative and positive pressure ventilation. Everybody on the planet that's healthy breathes by negative pressure. You create a vacuum. Your diaphragm contracts, it goes flat. The pressure gradient from outside your body to inside your body, air goes in. This is a manual function that we do. The reason that negative pressure ventilation works better than positive pressure ventilation is it's called the cardiorespiratory pump. Your breathing helps blood move around your body. So that negative pressure that you create intrathoracically helps with the preload, helps the blood move. They work together as a team. And then you come across somebody's going to do positive pressure ventilation, whether it's a back valve mask or it's a non-invasive ventilation, or it's a ventilator. Now we're going to do just the opposite. We're going to push air in, positive pressure ventilation. The problem with that, and I mentioned it earlier, you're going to get a drop in blood pressure potentially. You could have damage to the lungs that could be permanent. If you're using a mask instead of an ET tube, you get air in the stomach, they could vomit and aspirate. So positive pressure ventilation comes with some significant things. Now, so you're not going to see, I can't imagine you would see somebody on a negative pressure ventilator because they really don't exist. There's some things out there that help with negative pressure, but I'm not sure I would call them ventilators. If you remember the old pictures of the iron lung, that was creating a pressure change with the head outside the iron lung compared to the pressure inside, so air would move in and out. Obviously, pretty limiting lifestyle, though. So the hazard is creating the things that's listed there that I've already mentioned. We can cause some bad things with positive pressure ventilation. That's why you'll hear the therapist talk about lung protective ventilation, because we could end up saving somebody, but now we've made them almost like an invalid because we've damaged their lungs so bad for improper ventilation techniques. And it can happen quickly. People say, well, we don't have the patient that long and at pre-hospital. It doesn't take long, that type of thing. So we have to be aware of these issues. So there's the iron lung. I've probably seen these old photos before. So high frequency oscillation. This could be somebody that you're transporting that generally has like a cystic fibrosis patient where they get a lot of thick mucus that has to be, try to break it up. So they do these chest wall oscillations. There's actually a company called ABM that makes a device called, they get two devices they make. One of them's called a clear and one's called a cough. The clear device is something that uses oscillations that you're breathing through it to loosen everything up so that a patient can cough it up. A lot of these patients, the stuff is so thick that they need something to get it broken down so they can get it up. The downside of that is some of these patients do not have a strong enough cough to get it out once they get it loose. And that's the sister product. It's called cough. It actually creates an artificial cough. So for those patients, I mean, I've had patients where you get them all loosened up and you tell them, okay, give me a good cough. And I get this like half-hearted, type thing. Well, that's not going to work. So now they've created these devices that do oscillations, and they have to measure the frequency and the amplitude. It has to be a certain speed of the oscillation and a certain strength of the oscillation for this to work. So that box that's next to it is something that they would set the frequency and the amplitude of those oscillations. And you figure out what's going to work for that particular patient. So it's a non-invasive airway clearance therapy that they would wear this probably several times a day. It's not something they would wear all the time. It's an inflatable vest, and it's just rapid oscillations. So you might see this in a patient that's being transported. And this is the cystic fibrosis, bronchiectasis. people with neuromuscular weaknesses where they can't generate a really good cough or take deep breaths, then they have to have these artificial ways of doing it. Then you might see something like this, the biphasic QRS ventilation. This is where they've got the chest surrounded and they're going to change pressures inside that will make the air for them to be able to ventilate. It is a form of negative ventilation. Haven't seen one of these in a while in a hospital setting. This is something you might see at home that somebody sleeps with, that type of thing. So it's a hard shell over the chest, and it alternates between positive and negative to assist the patient to inhale and exhale. If you got somebody that has a neuromuscular disease and they're having trouble with this would be something that would be a lot more comfortable than having to wear a mask, or obviously intubated or trached or anything like that. So secretion clearance is a big deal, cough stimulation, and then the oscillation therapy all built into one. So you can see the difference comparison between the two is the oscillation is almost always for clearance. The one with the ventilation is for moving air in and out. It oscillates the chest compression where one changes from negative to positive. So you can see these devices are doing different things. It's conceivable you could have a patient that does both because they're having trouble loosening up secretions as compared to removing them. So positive pressure ventilation basic guidelines. Understanding the tidal volume. Remember that 5 to 7, 6 to 8 tidal volume at mLs per kilogram is really, that's part of the protective ventilation. So if you're going to put somebody on a ventilator or you're transporting some ventilator, that's one of the things you're going to look at. They're going to provide you with, for a transport, what the ventilator settings are. You want to make sure that they are what they said that they were. They're going to hand you a document that's going to have it, and then you're going to have to monitor that. So it's the tidal volume. We don't want it being too high. You can use that number as a standard place to be. So polyp pressure pushes air into the lungs, increases intrathoracic pressure. I told you about the hazards that come with that, which is we can create some problems. You got patients with weak lungs. You got patients like with emphysema patients, that type of thing. And if we push too much pressure, we end up with pneumothorax, subcutaneous emphysema, dropping the cardiac output. So a lot of negative things can happen if we, by accident, put too much of a volume in there and creating a problem. The barotrauma, volutrauma, patients going to deteriorate because of that. So the size and type of portable laptop-sized vents focused to large ICU, I don't see much of a difference anymore between the high-end transport vents and an ICU vent. They seem to have some of the same modalities and therapies that whether you're ICU or transport. So the key thing is don't hurt the patient. Kind of makes sense. We're going to prioritize lung protective strategies. So that means we're trying to reduce ventilator injuries. Ventilators can be very damaging on patients if not set up correctly. So we're concerned about the barotrauma, the infection possibility. Just about every vent patient over time is going to end up with an infection. I used to go to Sable Palm where they had a bunch of kids on ventilators, and almost every one of them had a respiratory infection all the time. A lot of them were trached. Their trachs were infected because they tried not to overutilize antibiotics, but infections can be a big deal. We want to have optimal PEEP. We don't want to put too much pressure. 5 is a good place to be. We want the minimum FiO2. We want to reduce the atelectic trauma because of the pressure and the volumes that we're using. And we're still worried about that oxygen toxicity. But as I reviewed with the oxidissociation curve, is there are other things I have to look at than just oxygen toxicity. I want to be aware of it. I want to use the least amount I can, but I got to make sure that that pH and CO2 are within norm so that we're getting that association and dissociation occurring. So the goals is you want to decrease work of breathing. I've never had a patient that didn't want that. It's an artificial mean to maintain physiological ventilation. When the patient can't do it anymore, that's when the machine comes into play. We're going to provide oxygenation for sure. It's a means of CO2 removal when the patient can't do it. And it also decreases myocardial work. It decreases their work in the whole body if they don't have to work hard to maintain that pH, maintaining proper CO2, maintain oxygenation, gives the patient a chance to rest and heal. So common starting modes, oh, sorry, back up a second, is what are we looking for here? Hold on a second. Okay. Typical adult settings, tidal volume, 6 to 8. Mentioned that a couple times, 5 to 7, you're in the same ballpark. Respiratory rate, 12 to 16. This is if you're starting, because you're going to make adjustments will be made off assessment and off of a blood gas. A lot of people like to start out with 100% FiO2, but if I've already got some indications of what they were already on, you want to maintain what they were already on. You're going to have the blood gas, you're going to have the report of what the settings were. You're probably going to mimic those. PEEP of 5. I would never want to go below 5 because now I got to worry about alveolar collapse. That has to be popped open on every breath, more work, and causing more trauma. The more times we have to pop them open, the more damage and problems that we can cause. And then I want to have an inspiratory flow rate between 40 and 60. And I've already talked about the flow rates is so that they're not fighting the machine. And that's, I guess I said earlier, that's one of the biggest indicators is when they're fighting. So respiratory monitoring under ideal conditions. These are the things that you would want to monitor as much as you can. The SATs, the ABGs, all the stuff you've heard about all this all afternoon. The tidal volumes, the pressures, plateau pressure, which is kind of like tells you about compliance. And we'll talk about another time about plateau pressures. How well is the patient and the ventilator getting along, the synchrony? We're looking at an initial blood gas. Generally, they're going to do a blood gas after 30 minutes of being on the ventilator to see how they are managing it. And then we're going to do follow-up ABGs based on the patient's condition. And that policy can vary by facility. So ventilation management, hypercapnia, hypocapnia is the highs and lows of the CO2. Is we want to be able, if they're hypercapnic, I got to increase rate or increase volume. And if it's hypocapnic, I've got to do just the opposite of that. Oxygen management, if hypoxia occurs, consider recruitment maneuvers. They'll actually, on a ventilator, they'll do an actual hold, where you kind of make the patient hold their breath a little with pressure on to try to recruit. You can do it that way. Oxygen targets is we're going to use this, the PEEP to increase the oxygenation. Obviously, our FiO2 can do that. But I mentioned about what a maneuver is. There's different things that therapists will do to try to recruit alveoli. Some of the common characteristics, this is a transport ventilator. It's generally electric or pneumatic. Some can be both. It's cycling is when they go from expiratory to inspiratory. It's going to cycle to the next breath. Those are some of the parameters that can be adjusted: the mode, tidal volume, inspiratory pressure, respiratory rates, FiO2, PEEP, all those type of things are under the control of the clinician running the ventilator. And then the circuit, pretty much standard circuits. They all have the same size connection from ventilator to ventilator. So just about every circuit will work. And they have alarms, a lot of different alarms from everything from low pressure, high pressure, all kinds of alarms that they can actually go in and set. So patient ventilatory, to get them to synchronize, is we want to make it where they don't have to add more breaths. They don't have to trigger it because we don't have it timed right, or we don't have the flow right, or it's not cycling fast enough between expiratory and inspiratory. So some of the management, wanted to get to that. I've already mentioned those three categories there. So low pressure alarms, if you get a low pressure alarm, first thing you got to check is the circuit got disconnected or the circuit came off the ET tube. High pressure alarms generally are stuff where the tube got kinked, the circuit's kinked, they've got some sort of an airway obstruction. So you look at those things first. I was always taught when a person ventilator goes into an alarm, the best thing to do is take them off the vent real quick and bag them until you figure it out. That type of thing. So we're looking for those problems right off the bat that we have to readily correct as soon as possible. So I mentioned all of that. So these are just some of the different modes. And again, it could be whole courses on this, but assist control is generally where the ventilator is running everything. The synchronized intermittent means the ventilator is going to give a number of breaths, and if the patient wants to add more breaths in, they can. Pressure support ventilation, that's giving that, like with BiPAP, that you're going to have a kick when they inhale. Pressure regulated, every breath's got to hit a certain pressure. CPAP mode, BiPAP mode, we talked about. CPR mode, I've already mentioned. So the things that you can set, obviously the oxygen percentage, the mode, the rate, the tidal volume, pressure support. Remember the difference between the inspiratory and expiratory. PEEP. There are additional settings that can be adjusted, but usually be set by the respiratory therapist. I think the medics should probably stay within this realm at this point. They're going to give you the patient already on the vent. Only time that you would have to make those changes if the patient deteriorates or something occurs that would cause you to make that adjustment. Other things you can set: oxygen, obviously, respiratory rate, tidal volume, inspiratory pressure. Think of event settings like a phone number, group oxygenation variables. These are the variables that you can play with using the blood gas to make those changes. Hopefully, in short transport, you won't have to make any changes, but you need to be in position to see when something's not doing well and what changes I'm going to make to do that. So if the pH is the problem, fix ventilation. If oxygenation is the problem, fix the FiO2 and PEEP. Those are your first steps if you see one of those two as a problem. So to prevent secondary ventilation-induced injury, when the patient is stay within that tidal volume, is low tidal volumes. You see us, they start in 4 to 8. Again, 6 to 8, 5 to 7, you're still in the same ballpark. So lung protective ventilation is valuable because it prevents harm. We don't want to make these people worse after they get through the emergency side of it. The peak pressure, that's how much pressure is taken to get the volume in that you want. The plateau, if you look at, let me put that up right there. If you look, that's a wave that will show up on the ventilator. You can see the peak is the max pressure, and then it plateaus for a second. That shows how compliance. If that's really high, you've got stiff lungs. And then you've got the, what was the driving pressure is how much pressure it took to get chest rise or lung expansion. So let's see. So high peak pressures, high plateau pressures, high resistance, high PEEP or PIP, peak inspiratory pressure. We don't want these high pressures. That's causing harm. That's causing the barotrauma and the volutrauma type thing. The circuit obstruction, as you can see there, is used to be a big problem with water condensing into the circuit, causing it higher pressures to go up and the alarm would go off. But anytime a filter's blocked, tubing is kinked, you're going to get an alarm. ET tube being kinked obviously would make sense. Bronchospasm, laryngospasm, patient biting the tube. I've had people literally bite and make a hole in it, that type of thing. That's going to set off an alarm, and those things would have to be treated, obviously. So the high peak inspiratory pressure or plateau pressure indicates a lung compliance problem. They got stiff lungs. They could be in heart failure. They could have pulmonary fibrosis. They can have all kinds of problems that make your lungs stiff. And so those pressures are going to have to be high, even though they can be a little bit more dangerous. So that mentions some of those. So PEEP prevents electrauma, transport reality, temporarily clamp the ET tube. If you're changing from the hospital vent to your vent, that type of thing, we just don't disconnect it and go to the next vent. You need to clamp the tube, make the change very quickly, because you're going to lose your PEEP if you don't do that. And so now the patient's not going to ventilate very well. Why it's reestablishing that PEEP again could cause damage to the alveoli, but the patient could deteriorate in the short amount of time it takes to go from one ventilator to the other. There's actually valves that you can get that would be in line, could add a little bit of dead space, but not much, that when you disconnect the circuit, the ET tube is not open to the environment so that you don't lose the PEEP. It's that critical that you don't do that. So avoid bagging with zero PEEP. That creates a lot of problems that sometimes they can't recover from. So hypotension after the PEEP is increased. We're creating a reduction in preload. Decreased preload in septic shock. Can be septic shocks become a big deal. These people end up with a preload problem, and then we're positive pre-pressure ventilation, and we're making it worse. So lots of PEEP during move can cause de-recruitment if I have a loss of PEEP. That's what I was talking about earlier. Alarm triggers, again, there's the list of alarms that you'll have on there, but it'll come up and tell you what the alarms are. Clues, patients fighting, chest not moving, sats are falling, CO2's going up, that type of thing. Disconnect from the ventilator. If you're not sure, bag them with a mask until you figure it out. Go back to your basic settings if you have to, and then work your way up from there. Circuit checks, equipment failure, you can potentially have that. It's almost always going to be related to the circuit or to the ET tube. You know, not really much of the others that end up having a problem. And initiate backup ventilation, that's the BVM, or a second ventilator, which probably won't always be an option. Always have a BVM to the patient's side. Failure happens faster than anyone expects. You get caught off guard. That's why people shouldn't be writing reports, and the people in the back should not be distracted. Somebody needs to be watching what's going on really at all times. Waveform capnography, I'm going to kind of go through that very quickly here. I feel pretty comfortable if people have a good understanding of capnography. Permissive hypercapnia, sometimes they purposely want to have a little bit of higher CO2. It is patients with ARDS, other lung conditions, accept elevated CO2 to prevent ventilatory injury. I don't want to overpressurize this person, causing damage to their lungs, so I may have, and I've caused them to tolerate a little bit higher CO2 so that I don't cause significant damage to the lungs. So here's the goal, is you look at the tidal volume still in the lower end. I'm trying to limit the plateau pressure so I don't cause lung trauma. You can see the barotrauma. I have to accept the higher CO2, got to live with it. And it improves the outcomes for these people with ARDS. Trade-offs, hypercapnia. You might get a little bit of acidosis with that. That's okay. We're monitoring for hemodynamic effects by doing it. So the conclusion, not going to read that to you, is a lot to read. If you have any questions, that's my personal email address. Feel free to send me the questions. I hope that this was informative and is helpful, and get your interest in learning a little bit more about how these ventilator and respiratory patients are where they are and why you do what you do.